Good morning, everybody. My name is Angela Alder. I'm an Assistant National Director in the Office of Public Health. So you're all very welcome here today. We have a huge attendance online. I think we have over 1,600 people. Some are still joining. So welcome to everybody online who's coming in here today. We have a number of people in the room. So thank you to everybody here and Dr. Stevens. And we have a number of speakers. So you're all very welcome. I'd like to take this opportunity to welcome our Chief Executive Officer, Mr. Bernard Gloster, who's here with us today, who'll be launching the strategy, and also Professor Mary Horgan, who's the Chief Medical Officer from the Department of Health. So you're both very, very welcome. So we've a very packed agenda, so welcome to everybody in line. And we'll be having a panel discussion at the end, so I'm going to encourage all of the people online particularly to put in your questions so I can put them to the panel, because I'm sure you're all interested in the strategy, and it's particularly the next 5 years. It gives you an opportunity to engage with everyone in the room. So I'm going to introduce you next to our speakers. I know you're all looking at an agenda online, but just to let you know who's here with us and who'll be speaking, we have Dr. Colm Henry, who's here with me, who's the Chief Clinical Officer, and Colm is also the project sponsor for the strategy, so you're very welcome, Colm. We've also Dr. Mai Mannix, and Dr. Mai Mannix is the Regional Director of Public Health. And Dr. Mannix will be sharing with her experience of a health equity region, which is very interesting to all of us. So we look forward to that, May. We'll also have a short video, so that will be interesting. We've Dr. Cuddihy, who's our National Director of Public Health from the Public Health Office. And Dr. Cuddihy has been responsible for leading out on the strategy over the last year in particular. So you're very welcome, Dr. Cuddihy. Then after that, we have Tiberius Pereira, who I'm just trying to locate in the audience, who's also, sorry, Tiberius, apologies, who's our patient voice. And we particularly welcome you, Tibbs, because it's important, I think we all know, that to the fore and to the centre of the strategy is the patient, but really the community. It's much more than being a patient, it's about being a community, and we're all part of that ourselves. So you're very welcome, Tibbs. And last but by no means least, my colleague here, Dr. Louise Hendrick, who I actually work with, and I'm delighted to work with, who's a consultant in public health, but who's also the project lead for the strategy, and who's played a key role in bringing together all the stakeholders, of which you're a small number, but has engaged widely across the system. So I'm delighted to have Louise here today. So I think that's enough of me talking, and I'm going to hand you over now. I'm going to invite our Chief Officer, Bernard Gloster, to officially launch the first HSE National Public Health Strategy from 2025 to 2030. So you're all very welcome. Thank you, Bernard.
Thank you very much indeed. I always remind people when there's webinars and live things and you're in the room, it's easy to forget the camera. So watch your grimaces and your smiles and your facial expressions. Those of us like Colm Henry and myself who are well versed in Oireachtas hearings know you're always on the camera. So good morning, you're very welcome. And it genuinely is a huge privilege to be here. I'm delighted to welcome the CMO, Professor Mary Horgan, and to thank her and the department for their support for this. I also want to extend my thanks and my good wishes to John Cuddihy and to Louise and to the entire public health community who have essentially produced what I believe is a really reader-friendly, very instructive, not full of jargon, clear direction of travel with good evidential basis beneath it for why it is what it is. And sometimes strategy becomes a very academic exercise with no hope or possibility of implementation. If you'll indulge me today, I do want to say a particular word of welcome to my great friend, my long-time friend and colleague, Dr. Kevin Keller, an absolute stalwart of public health in this country when it was rarely talked about. So it's lovely to see you, Kevin, and you are so welcome. One of the things that struck me when I was reading the document, and yes, I do read them, believe it or not, CEOs get time to try to read things. But if you look on page 7, there's a lovely opening paragraph on page 7 of the document, and it's a synthesis of Atchison and the World Health Organization together. And at the first half, it defines what public health is. And it defines it both as a science and an art, but about something that talks about promoting health and preventing disease, rather than responding to illness, which of course we have to do both. And then the lovely blend with the World Health Organization, which takes us beyond the limitations of the absence of illness and talks about our mental health, our social well-being, our sense of well-being of ourselves. And to me, fundamentally, when I look at the challenges right across the health and social care system in Ireland, of which I've been a pleasure to have served in so many different ways for almost 38 years, everywhere you look, you see the impact of disadvantage when it comes to the determinants of health. And yes, we have to not have our heads down. Look how far we've come. I was speaking recently at a lecture, and I was talking about the fact that on the foundation of the state in 1922, your life expectancy at birth was 57. Your life expectancy now is up in the 80s. And why? Because of good social policy, housing, education, income, because of behaviours, lifestyle, and because of advances itself in healthcare, both in terms of access and in terms of the progress of things like therapeutics and so on. And look where we've come to. But yet we know we have a way to go. And one of the things I really am delighted with in terms of our public health community here in the HSE is that focus on the groups where we know there's significant inequalities. Whether they're people who experience homelessness or whether they're members of the travelling community, and I've such a long connection with Traveller Health and so many other groups and people in socio-economic challenged constructs. And you'll hear later from Mai Mannix about Limerick and about approaches there that are still being explored. And it's wonderful to see, because we have to keep trying. We may fail, we may come up short, but we have to keep trying, because we know that where health is at its worst, it's in the wider context of inequality. And that's where we have to try. Also, I think it's fair to say, when we look across the population and the demographic that we have, we know that there's a way to go in terms of having to provide services to responding to conditions like frailty as people live longer because the quality of life isn't yet where we might want it to be, responding to the prevalence of chronic disease and its impact on our healthcare system. But I hope the days are reducing when we talk health and well-being, but we don't fund it to the extent that we should. And where we start now, and have done for perhaps the last decade, to see a trajectory of growth, of investment, of attention to prevention, to promoting positive health. And fundamentally, that's what a public health strategy is. That's what a public health strategy must do for its people. I have no doubt the living out of what's in this document, much of it being done already, I have absolutely no doubt that the living out of that document will contribute fundamentally to a whole generation of people experiencing less ill health, and that's for the children, and for a whole generation of people experiencing a better quality of life in that longer quality of life. Having public health in the HSE is a critical dimension of what we do. It's a critical part of the construct. And then the relationship at policy level with the department is so important. That almost synergy of policy and of operation is, and I believe public health is one of the places where that can be achieved to a very high standard. Because fundamentally what we do in public health in the HSE and what the CMO does, it has to be an all-government, an all-people and an all-organisation approach. It has to be something employers see as part of their remit. It has to be something schools and colleges see. And it has to be something that our public hear so often. So I'm delighted to officially launch this strategy, and my sincere thanks to Colm Henry and to John Cuddihy for the leadership that they have and continue to show in bringing this to where it needs to be. Thank you so much.
Thank you, Mr. Gloster, for officially launching the Public Health Strategy. I am now very honoured to introduce Professor Mary Horgan, who's a consultant in infectious diseases, and she's also the Chief Medical Officer for the Department of Health and was previously the President of the Royal College of Physicians of Ireland. So thank you very much, Mary, and you're very welcome.
Okay, and thank you very much. I suppose I'll start off by saying having the CEO here to launch this underpins how important this is to the health service. I think that needs to be acknowledged straight up. I joined the Department of Health in August 2024, and I'd say a few weeks later I had a conversation with Colm about the strategy, and really we both felt, and I felt very strongly, this needs to be done, led, owned by colleagues in the HSE and the public health leadership. And that was the start of what we have here today, a new public health strategy that will be delivered on. It sets out the roadmap for what's going to happen in the next 5 years. I suppose my own personal engagement with public health goes back a long way. I'd probably start with 1997 when I was appointed. I was the second infectious disease person to be appointed in the country, and worked really closely with Liz Keane and her team, and I see Anne Sheehan here today, looking at everything from HIV's antenatal screening, which we brought in. And I will say, as a Kerry woman, but I will say that Cork did lead the way on a lot of these initiatives, outbreak control, really understanding the whole dynamics when it came to STIs and how we prevent them. So we had a very a strong relationship with colleagues in public health in the South-Southwest at the time. Then moved into UCC. I was Dean of the Medical School there, and saw the transition and supported the move from the Faculty of Public Health to the School of Public Health in UCC. And we all know how strong that is, led by Ivan Perry at the time, and just to acknowledge his work in it. To the Royal College of Physicians, delighted that Bernard acknowledged Kevin's big contribution. He's now Dean of the Faculty. I see former Deans of Faculty, Patricia Fitzpatrick here, and brought them really as an equal partner into the College of Physicians. All of the 6 faculties there, we are all equal. And I think that I was instrumental in ensuring that public health really worked closely with the Faculty of Pediatrics and Institute of Obstetricians and Gynecologists, and got rid of all of those silos, because that's what public health does. It transects all aspects of health. And as the CEO said, this is a government, cross-government, cross-sectoral way of doing things. I think it's important to realise that the document isn't just a set of policies, it's a commitment to the well-being of the health of our nation. Our nation and its population has changed considerably over the last a few decades, and with that we need to change how we deliver care, really look after the most vulnerable in our population. And I think John Cuddihy, leading on this with Louise and all of the other colleagues here in public health, understand that need, that population need. Often as a frontline clinician, we just do one-on-one. The real impact, and I say this to my colleagues in the Department of Health, and they don't realise it, is at the population level impact that you have, giving the best value for money, the best things we possibly can do. I'm also conscious that we research, often done through people like the HRB, work with HIQA is really important, and it's about us working together with the common purpose of making every person in the country, irrespective of whether they're a newborn infant, and we'll see the impact of RSV immunisation, right through to older age, that they get the best possible care, have the healthiest possible life for as long as possible. And that's what this new strategy is about. I'm particularly privileged to be working very closely with colleagues in public health and have trainees coming in here. I just see Eamon James Gilmore here, and my 2 colleagues, Ellen Crushell and Philip Dodd, who work very closely with colleagues. We are here to support you. We do policy, you deliver on that very, very effectively. So congratulations to John and to Louise, and thanks, and we continue to support all your great work in the country. Thank you.
Thank you so much for that, and we are delighted to have the support of the department throughout all the development of the strategy and going forward really into the development of the action plan. So thank you, Professor Horgan, thank you. I'd like to now welcome Dr. Colm Henry, the Chief Clinical Officer for the HSE, and Colm is here really to give us his perspective on public health and also the landscape within which public health is going to be launched. So you're very welcome, Colm.
Thank you. I'm note at the beginning, Mary was introduced as a consultant in infectious disease. I'm a consultant geriatrician, but one of the things I've come to realise since I was appointed CCO in 2018 is if you're not working in public health, trained in it, you actually end up working for public health. I didn't realise I was working for Kevin Keller for many years, and a succession of other public health leaders are here in the room. And it is funny, but I actually mean it too, because you can't do a job like this. You can't embark on a clinical leadership job unless you see yourself as working for public health, and that's in small letters and in big letters, because that's what the job is about. When I came, I mentioned I came in 2018. It was a very different place for the HSE then. There was no talk of regions. Public health was a disparate workforce, and I inherited a Crowharrith report, which had built on the criticisms of recruitment, retention, and a somewhat demoralised workforce. That really, because of the way they were dispersed throughout different functions, they were weaker dispersed than they would be as a single entity. And of course, we had the Scally report then, which talked about the importance in the aftermath of the crisis and screening and of the importance of public health leadership. And it's apt that we're in this room here, which was the kind of operations hub during the pandemic, that we would launch this strategy. Because as we were talking about and maybe agonising over what we needed to do to get the maximum benefit from public health, a virus emerged from Wuhan in China, and we saw the enormous contribution and leadership of public health. And I think it's worth acknowledging that today, the enormous national leadership demonstrated by Tony Houlihan, by Ronan Glynn, by Kevin and colleagues, and the regional leadership by some people in this room and many who are listening, who in their own diligent way that was not publicised, helped to prevent outbreaks, to protect people, to use the skills that they had in training and protect the Irish population in a way that we all felt minded. And then the vaccine programme came about. And it was again, we were working for public health, because public health said to us, no one can get left behind. Everyone's got to get included. And in the way that some of the rest of us are conditioned through our training, you're conditioned to look at a segment of the population, at a specialist outlook in terms of the population. And it was because we work for public health now, or should do, that we picked up everybody as we went along. And that was quite literal. And people like Kevin here in front of me wouldn't let us rest until we had addressed every marginalised population, no matter how difficult it was. Lots of reports, and there has been, I hope, lots of actions. And we began, I thought we had 4 domains of public health when I went through my initial rapid tutorials, and that was health protection, health intelligence, health improvement, health service improvement. But can I say, and I'm trying to say this as politely as possible, I've learned that public health consultants can be very robust in their advocacy. And one of the most robust advocates is Abby Collins, who added a 5th, which is child health as one of those critical arms. And why wouldn't it be? When you eventually listen and you acknowledge, is we're building a future for people. We're looking at the social determinants of health. We're expanding our awareness that the determinants of health are laid down in very early childhood. And the rest of us who work in hospital systems that deal with what happens when people fall into the river and try to pick them up can be effectively prevented if you resolutely and with belief address the underlying determinants of health. And what is the point in treating illness if you're returning people to the environment which created that illness in the first place? So we did deliver on the promise, and there was more robust discussion and robust engagement, and the solution or the outcome has been consultants in public health. But it hasn't just been about achieving that status and that recognition and authority that was long overdue. It's that they're working in teams, and this was a really important part of Crowharrith. It's not about the consultant. The consultant is clearly the lead of a team, but it's about these arms of public health working together with multidisciplinary teams in each of those respective entities. And that's and the expansion of the workforce, I'm really proud of what we've achieved. Yes, many of it was built in the back of the pandemic, and it's ironic somewhat that we did so in the back of what was a health protection crisis, when Crowhearth was drawing our attention to the fact that we needed to move our focus away from an overt health protection crisis. But I would add in that even in the peak of the pandemic, and Kevin will know this, there were more, to use that word again, robust discussions about the impact of social restrictions and the other aspects of public health, education, child health, and so on. And it was because of the actions of some of the people in this room that led me to work with them in advocating for changes as we went along through the different stages of that response. So we have overhauled. We have a National Office of Public Health. I'm delighted and just want to acknowledge my colleague John Cuddihy, who's provided great leadership and wise counsel in his tenure in that role. We have regional departments now. Before there were REOs and regional clinical directors, the first people appointed were Mai Mannix and her colleagues in the regional departments. And I've already seen the fruit of that. And May will be speaking about that. And I attended a course in a King's College in London with May on population planning, and I saw the enormous potential this has, this cross-sectoral work. But I saw what they do in the UK, where public health specialists work with local councils, work with planning officials, work with schools, all addressing underlying social determinants of health. I saw the extreme heightened sense of awareness they have of social inequality, of the importance of bringing everybody along and leaving no one behind. And it's a vision that I think we should transplant and transfer here to Ireland. I know Dermot, who's here, I think, is working on looking at metrics for inequality, and I think it's really important with the board and the HSE, who I'll be meeting later today. That's where boards really come in useful, is you start measuring and you start comparing, and then there's an awareness that people are being left behind, and then they ask you what you're going to do about that. And we're probably not at the level of awareness that we should be at, but we're getting there. So lots of challenges ahead. I'm acutely aware as a geriatrician of an ageing population. Many of yes, we reached 82 years, but on average 14 or so years of those are lived in relatively poor health. And that's something we have to plan for. We have more people living with chronic disease. We have ongoing death due to preventable causes. And it's people in this room who have worked with me, whether it's on alcohol prevention. I know Mary will continue the work of working with government in trying to raise awareness about the impact of alcohol advertising, for example. And there's more work to do on cigarette smoking, and again to acknowledge the partners' work on vaping, and of course huge work in the area of mental health. Our vision, advancing health intelligence, delivering high quality public health, protecting the population, addressing determinants of health, improving health equity, and strengthening our health services. And just to underline that last point, which is my point of greatest awareness, if you like, because of my own background, I'm really anxious to harness the work of Abby, of Jennifer Martin and others in designing models of care that address the whole range of human illness, that HSE becomes an organisation not just of healthcare, but about health and about preventing illness. And that's my strong belief, and it has been from the beginning, and I'll say it again, is that the public health belongs in the heart of the HSE, in the heart of all our central structures, in the heart of the regions, and we all need, as I said, to see ourselves as working for public health. So just to finish up, I'm getting the notice that we have to wrap up. I want to really thank people. It's a day of a strategy, yes, it's a day of coming of age, it's a day of vision about a healthcare delivery organisation, which is the HSE, which has inclusivity at its heart, which views healthcare in a scope that is broad, not narrow, and where we see, as we did in that lovely, for a time during the vaccine programme, we visualise ourselves, we set a vision for ourselves that no one gets left behind. So just to thank Louise for her drive behind this and patience, John for his leadership, all the National Public Health, Tibbs, who's here, I think, representing all the patients, Mary and the Department of Health for the support and sponsorship, Philip Dodd for his huge work in mental health and for, again, quietly supporting us behind the scenes, and for all of you who are listening, who provided your own leadership over the years. Let's look forward and let's get on with it. Gurmaigh, thank you.
Thank you, Dr. Henry. I think it was just interesting to get that insight to all the changes that you're all very familiar with that have gone on over the last 2 years in particular, a bit before that. But I'm going to introduce you now to Dr. John Cuddihy, who's the National Director of Public Health. Thank you, John.
Thanks very much, Angela, and thank you very much to our CEO, Bernard Gloster, our CMO, Professor Mary Horgan, to Colm Henry, Chief Clinical Officer, and Kevin, new Dean of our faculty, not just for being here today, but for the huge support over the years of the development of the Public Health Reform Programme and the development of the new model for public health. That support has been invaluable in relation to getting us to where we are. I want to take you through what's in this public health strategy, if I can. And we spent quite a bit of time in our engagements discussing what's the scope of this strategy. And the conclusion we came to is that this needs to be a strategy for the whole of the HSE and our wider stakeholders that reflects the vision, mission and values of the public health function. Because I suppose the mantra that public health work with and through others, I feel is more than a mantra. It's the only way that we can be effective in achieving our objectives. We can do literally nothing on our own within our public health function. Our vision is for the best possible health and well-being for everyone in Ireland. You'll notice that hopefully the wording in the strategy is that there's a lot of thought behind it through all of the engagements with the public health senior leadership team, with our wider stakeholders. And the word, I suppose, here is everyone. In that key theme across the public health strategy is health equity. And it's true that sometimes our innovations and our efforts to improve health and well-being can make the health inequalities that society experience worse if we don't address those who are most underserved, the most vulnerable in our communities. So the best possible health and well-being for everyone in Ireland. The mission is providing public health leadership in partnership with individuals and communities. We support and enable everyone in Ireland to have the best start in life and to live longer, healthier lives. I think you can hear the resonance there from the Marmot principles. And we did have the privilege of hearing Professor Michael Marmot in one of our national public health conferences. Within that mission, we aim to increase physical, mental and social well-being, protect health, prevent disease, build healthy communities, address health inequalities, enhance equity and access, drive and harness innovation, improve health services and provide a high-quality public health service. The voice of our patients, service users and commitments, I think it's fair to say, was our top priority in the development of this strategy. And in that, through Louise's leadership and the help from Tiberius, who's in the audience with us today, we were able to conduct focus groups from several different communities and community groups, and they're listed here and they're in the strategy. And out of that, I suppose, these themes emerged of what was of most interest to these communities and individuals in relation to the health of our population: access, communication, prevention, language, importantly, that we communicate as effectively as we can across society, technology, vaccine hesitancy, social determinants, trust, discrimination, and the pace of change. I have a broad list, ambitious list, but very valuable insights, I suppose, into the thinking of our partners in the community and community organisations. And out of that, we collated what's important to our patients, service users and communities. And these are the themes that came through, again, that we've incorporated into the strategy. Our values and principles in relation to developing this strategy, and as I suppose reiterate that it's a strategy for the wider HSE as an organisation and beyond. So we built our values and principles on the values of the HSE as an organisation: care, compassion, trust and learning. But in the course of, again, the engagements, about specific public health values, we included excellence, equity and communication, because specifically in public health, these are standout values and objectives that we try to work towards. And through the engagement then across public health and with our stakeholders, we developed the principles for the way in which we would aim to work, working together across public health domains, integrated regional and national public health working, and then working with all of our stakeholders across the HSE, local authorities and beyond. So these were the, again, principles. There's a lot of overlap, I suppose, between what the community partners are telling us they want from population health approach, and within our public health function and among our stakeholders, what we aim to achieve as well. The prevention focus, the health equity, community engagement, evidence-informed practice, a population-based approach. We have a project at the moment between RCSI and Health Service Improvement led by Jennifer Martin that's delving into defining the population health approach, but and I suppose importantly, engaging with a very broad range of stakeholders in doing that. And I think the process there is as important, in my view, as what will be produced at the end, because that engagement with the stakeholders is building those relationships and co-designing the concept of what we all mean by a population health approach. The collaboration and partnership, digital transformation. We have our National Immunisation Information System up and running for the primary childhood immunisation programme. The outbreak case and incident management IT system for public health will go live in January, and we're setting out on the development of a child health information system. The sustainability, resilience and preparedness. We in public health have been joined now by our colleagues in health and wellbeing, in climate and in global health. And that transition, I think, formalises and enhances the type of working relationships that we've had and the synergies with those functions up to now. So that's, I think, very exciting development. The 6 priority strategic aims, I think Colm alluded to them. Advancing health intelligence, deliver high quality public health, protect our population. We build on the health protection strategy that is already developed. Lorraine Doherty was instrumental in that, and Eamon O'Moore and his team in implementing that. And we will build further on that in the course of this strategy. The strengthen health services, address the determinants of health and improve health equity. The remainder of my slides, which will be circulated, and within the document, you'll see a breakdown of each of the 6 strategic aims into tangible objectives. Then, towards the end of this morning, Louise will talk about the next steps, but one of those next steps is to develop a strategic action plan. And again, in a very co-designed way, with a broad engagement over a number of months, because I think that process is going to be important, to develop KPIs so that we monitor what we're aiming to achieve. And I suppose I'm confident that by implementing this strategy, by implementing the strategic action plan's objectives and incorporating those into our operational plans and our individual work plans, that we will achieve that overall vision of better health and well-being for everybody. And to finish, there's an advert from one of the telecommunications companies where they're describing an achievement, their latest achievement in terms of broadband, and then they present it, and the response is, that's fine, but let's go again. And I think in public health, population health, we have to go again and again and again. And today, I think in the launch of this strategy is a starting point again. So thank you very much.
Thank you, Dr. Cuddihy. And obviously just time doesn't allow, and I'm just going to show those of you online a copy of the strategy there, and the breakdown really of all the detail of what John refers to is in that strategy, and it's up online for those of you there, so you've access to that as well. So thank you, Dr. Cuddihy, and congratulations again to you and Dr. Hendricks, because a huge amount of work has gone into developing of what is now just this little glossy document, but there's months and months of work with stakeholders in there, so thank you. So the next part really is we're going to have a short video. So our speaker after that will be Dr. Mai Mannix. So we're going to go straight to the video first, and then after that we'll have Dr. Mai Mannix, who's going to speak on the health equity region. So thank you, everybody.
If we look at the health of most populations, United Kingdom, Republic of Ireland, elsewhere, what we see is that health inequality is not a footnote to the real concern about health of the population. It is the real concern. The gaps in life expectancy between the most deprived areas and the least deprived areas, 10 years, 15 years, 20 years. More than that, health follows the social gradient. It's not just rich versus poor, but the greater the deprivation, the poorer the health. It's life expectancy, and even more crucially, it's healthy life expectancy. And if we look at what's been happening, certainly in the United Kingdom, and I don't think the Republic of Ireland is very different, that as health inequalities have increased, health for the poorest people has got worse. I heard this morning about the rise in disability in young people in deprived areas in the Republic of Ireland. So health inequality is the challenge of our time.
Good morning, everyone. It's a privilege to be here this morning and to be able to speak to you about our health equity region in Limerick. I foolishly chose to speak after Michael Marmot, so we don't mind having a challenge, us people in Limerick. I'm going to talk to you, even though I'm the regional director for the public health in the Midwest, I'm focusing today on Limerick. Limerick, as you're probably aware, is a very rich city, rich history, culture, sporting city. Home to our birthplace to Terry Wogan and Richard Harris, among others. But there is another side to Limerick, and that's the side I'm going to concentrate on today. And I should say I have a conflict of interest. I'm a Corkonian living in Limerick, but they tell me I have dual citizenship at this stage. So this is a home to a family in our region. There are 5 children in this home, in this space. The 5 children live across the top of the picture there. There's an 18-month-old baby in the top right-hand corner. There are 2, the parents also live in the space. There is a hole in the roof and on the floor of the space. So you can imagine the health effects for that family. More respiratory infections, more likely to end up in hospital, etc. On the right, you can see God bless our home. I want you to keep that image in your head for the moment. This is the Midwest, and here you can see the different health networks across the region. Today, I'm going to focus on CHN 7 and 8, which are the north and south of the inner city of Limerick. I'm telling you a story really about Limerick today. Part of the story is this shows deprivation levels between the 2 census periods, 2016 and 2022. The orange indicates the more deprived areas, and I suppose this is from the north of the city, Ballinanty area. As you can see, it's getting more orange, sadly, so that's the point that, unfortunately, the situation is getting worse, not better. So, as you can see there, the population living in extreme disadvantage has tripled in that intercensal period. And just to say that the only 2 extremely deprived EDs in the country are in Limerick. And this is one of them. It's John's A in the island part of the city, as we call it. And you can see the stats for that area. 61% have the highest level of education of lower secondary or lower, and that compares with 23% nationally. So it's very stark altogether. And 72% in this ED are lone parents versus 24% nationally. I've put this slide in. You're very well aware that the life expectancy of our traveller population is at least 15 years shorter for men. The point of me putting it in here is to say that the data at the moment is very challenging. For instance, I can't actually look at the data in my city to say my CHN 7 or 8, their life expectancy. I can't actually do that at the moment. And I know there is work ongoing in terms of equity stratifiers, but that's the real challenge on the ground. We need to measure what we're doing. We can't even do that at the moment. However, this is a piece of work, and I acknowledge Emma, who's in the room here, who led this piece of work. This was looking at data of children, and we looked at Alice as well, I'm just presenting the children today, who attended the ED in University Hospital Limerick. And literally we had to hand code this, so it took months to do, because we can't do it in any electronic way at the moment because of the lack of health equity stratifiers. So it looks at the data over a year. But I suppose the point I want to make is you can see the percentage of the population is light blue, and the percentage of the UHL pediatric ED attendance is the darker blue. And the point is that the attendances from our poorer populations within the city, CHN 7 and 8, are much higher relative to their population. So, you know, it's 12.4% for CHN 8 relative to the population of 8.3%. So that indicates increased needs, perhaps some difficulty accessing services, etc. But that's the level it took to get that data. So, as others have referenced, we really want to prevent people getting to the point of ED and need to be working a lot more upstream on the social determinants of health. So when I presented this recently at another conference, and Senator Lynn Ruane was at the conference, said, we don't fall into the river, we're pushed into the river. And I think that was a really valid point. So how do we do that? Just to talk about health inequalities, you know there are differences in people's health which are observed across populations and between different social groups, or traveller population of much worse health, or disabled population, those suffering from mental illness, and those living in our deprived communities. As we said earlier, the health service can only influence 20% of people's health. So that leaves all of the other areas, education, housing, etc., responsible for the other 80%. So coming back to Professor Sir Michael Marmot, whom we met very recently when he was in Dublin, I suppose, and someone else has referenced this quote from him, what good does it do to treat people and send them back to the conditions that made them sick? If you think of the first slide that I showed you, of people living in that home, there's no point in sending them back, is there? So what we're doing in Limerick then is taking Marmot's 8 principles. We're specifically focusing initially on giving every child the best start in life. As you're aware, Marmot speaks about proportionate universalism. So the guy on the right in each of the pictures here, he needs a lot more support to achieve the same outcomes in terms of, service provision. So our Limerick Health Equity Region Oversight Group, I want to acknowledge, I suppose, the leadership of Mayor John Moran and Limerick City and County Council and our own REO, Ms Sandra Broderick, who are co-sponsoring this oversight group. And just to acknowledge Dr. Andy, who's the consultant in health improvement in the Midwest, and her team, who are the driving force behind this. This is our first meeting. And as you can see, these are the organisations who are involved. We have the presidents of the 3 universities across the region, the head of TUSLA, the Garda superintendent, one of the governors of the women's prison and Limerick Prison, Limerick Chamber. We have education very well represented, the Oscail School, the organisation for deaf schools, etc. So far, we began in May of 2025, and we've done a lot of work, I suppose, over the last year, looking at whatever data we have. We've linked a lot with other health equity regions across England in particular. And we have a very baseline, I suppose, report looking at the health of our population and our assets within the city. Our last meeting was last Friday, which basically looked at what we're going to do for the coming year. Big focus on co-production with our communities, because that is so key to anything that we do. Did want to say that one of our meetings we met Mayor Andy Burnham, who's the Mayor of Manchester. As you know, he was a former Health Secretary in the UK. And he was Health Secretary at the time Professor Sir Michael Marmot produced his first report. So he then went on to be Mayor of Manchester, and he has really laid out the health equity approach in that region. There were many lessons, I suppose, that we learned from Mayor Andy Burnham, but I've chosen to pick out 2. One thing he said was 10 years later, we're at the end of the beginning. And I think it takes time. It's what that's about, and patience. He also recommended this book, which is fascinating, and I would recommend everybody read it. It's, and if you hear it on Audible, it's written by this guy, Darren McGarvey, a Scottish guy, about his experience of living in an underserved community in Glasgow. It's eye-opening and heartbreaking, actually, especially in the way it demonstrated how the voices of that community were not heard or thought. I usually like to include this slide because it's, when you're speaking to different audiences, obviously the economic audience can have a strong, or the economic argument can have a strong, force to it. So that health contributes almost as much to income growth as education. So just to keep that in mind. This one is actually from a school in Moyross. It's the Corpus Christi School. And if you click on it, it will actually bring you to the most beautiful video where they sing Dreams, which of course is a song by the Cranberries, our own local to the city. And what we're hoping to achieve in Limerick is somewhere where they really will achieve their dreams and they're not dying at a very young age, as we've heard so much about in terms of drug overdoses, etc. I'm not going to play it for you, but look it up. It's just gorgeous. I suppose I'm ending with this quote because for 2 reasons. One, it happens to be written on the staircase where we have a couple of our meetings. So it's from Martin Luther King. You don't have to see the whole staircase, just take the first step. We're probably at the first step in Limerick, but There are a lot of people I'd like to acknowledge. So many, so many. But to say, I want to acknowledge the people of Limerick. They are amazing. The people in these communities. There is, of course, you know, huge challenges, but the people we've met have been inspirational and challenging, which is a good thing, in equal measure, and it's fantastic. Acknowledge the people who have been working so hard all of these years to serve these people. But I suppose what we're trying to do here is work differently, work in a collaborative way. Acknowledge the Mayor and the Limerick City County Council and the REO, our own oversight group, our own team in public health, our health and wellbeing team, everybody across the region, national team as well, who've been very supportive to us in public health, and the Child Poverty Unit and the Department of the Taoiseach. If I was to have one reflection, I have many reflections, but it would be to paraphrase Professor Sir Michael Marmot when we met him last week. And he said, well, you know, Gwent and Wales started with one city and quickly became a whole Marmot health equity country. And perhaps that's the thought I leave you with today. I do think the strategy is one of the tools we need to get there. So thank you.
Thank you very much, May. And look, I think you probably all found that very heartwarming. You know, we stand up here, we produce documents and we, you know, show you go to links, but you could feel the real compassion there for the people of Limerick. And I suppose what we're trying to achieve, it's not a strategy, it's about communities, it's about people, and it's really about making a difference. And I think seeing slides where you see the conditions people are living in, it's just a tangible reminder. So thank you to May. I think you've made, really brought alive the strategy for us today. I think that leads in very nice to Tibbs, who's with Pereira, is from Patients for Patient Safety Ireland. And Tibbs is here also to speak on behalf of communities and patients, which is core to the strategy. So you're very welcome, Tibbs. Thank you.
Thank you very much. Good morning, everyone. My name is Tiberius Pereira. I'm a member of Patients for Patient Safety Ireland. I'll just talk a little bit, very quickly about what we do and the role that we've played. I do wish to acknowledge John Cuddihy and Louise, Hendrick, and the rest of the team in the attention they paid to including me in this work. So the first thing we do is about empowering and engaging patients to be active partners and be active partners in their own care. And for us, it's really important that patients and communities have a voice and are involved in things like the development of the strategy, in co-creation, co-production, and then all the way through into actually implementation as well. So, the work that the team has done in understanding, I'm just one person, right? So, but it's understanding, as you can see in the graphic, understanding what people, what service users or patients, as well as what communities are saying, and that's built in right throughout. So, we do welcome that. We talk about bringing the voices of people to the forefront of care, and we want people to be able to experience the difference as a result of new strategies and new implementations. So that's really important to us, is that it's not about what one person says. It's not possible for me as a single person to represent all patients, but it's really important to make sure that people, every individual, experiences the difference. And finally, it's about creating this enabling partnership. So, what we do is we engage in collaboration and partnership, and I think, as Louise knows, that's we do tend to be a bit stubborn at times, but we try and be as nice as possible about it as well. So these are some of the aims that we, the kind of our own vision, and it mirrors very much what you see in the strategy as well. So it's about empowering and engaging each and every person, and this is particularly true for people who experience the worst outcomes. And it's really good to see and to hear all the previous speakers talking about the importance of actually understanding and caring for each and every person throughout their health journey. And the test for us is about every person really experiencing this difference. We talk about health equity, and that's very important. We follow, and we're members of the Institute for Health Equity and also the International Health Literacy Association, and so we're acutely aware of the influence on health equity, and I think it's obligatory to talk about Professor Sir Michael Marmot, but he talks about the relative inequality actually being, causing health inequity as well, so just leading to, worse outcomes as well. So, for us, it was really important to actually ensure that that the strategy applies to each individual across all the social determinants of health. We talk about this a lot, so for us it was really important as well to think about what does person-centered care mean, and person-centered care is about making sure that each and every individual is thought about and not left behind. We can see now how many people do feel left behind, how many people do feel disempowered, how many people are losing kind of trust in institutions, and this strategy can go a long way towards addressing some of those things. And as has been said, it takes a while, but it's good to see strategies like this in place. And we want every person to really have some basic knowledge, skills, and confidence about how to engage. How to make sure that they're able to take advantage of the services available to them. So really basic skills and confidence to enable them to engage. And we see, projects across the country, usually driven by individuals who also, who are doing a really good job of this. And it's a question of actually everyone learning about this, recognizing it, celebrating it, and making sure that it's being adopted across the country. So, this is the final thing. So, we nothing that I haven't said before. It's about, integrated care. So not just within the health service, and we talk about in the community, it's through community centres, through men's sheds. It's, understanding, more about social welfare. So really, when we talk about giving every child the best start in life, it's also giving all adults, a full kind of understanding and awareness of all the care that's available to them, not just within the health service. So, shifting left as much as possible, or upstream, as Mai Mannix said, it's, going upstream. It's about shifting left, getting further towards, the aims of Sláinte care, which is around prevention, it's around early detection, more about self-awareness and moving care to where people are. There's the inclusion aspect, but also making this more of a society thing as well. So, everyone playing their part, including people who are other agencies, other advocacy groups, the inclusion groups like Parvey Point and so on, all of whom we tend to have a partnership with as well. And finally, it's the use of data, as a big element of health intelligence and the use of data. And I think, the way that we see social media companies, and other tech companies really, giving all of us advertisements or opportunities to engage are very, very personalized. And I think there's a lot of progress that we can make by using data scientists and using analysts across the health service and across all decision-making groups, rather than it being seen as a centrally driven IT thing. And finally, we welcome the implementation of marketplaces. I know there are 2 regions in the country that are looking at doing that. So thank you very much. Very happy to take questions after this. Thank you.
Thank you, Tibbs, and it's great to hear just what you're doing, what the organisation you're involved with in terms of empowering patients, for all of us really as part of the community. So thank you. I'm next going to introduce Dr. Louise Hendrick, who's a consultant in public health medicine, but more importantly has been strategic to leading out on the development of this strategy with a number of other players, but I'll let Louise talk to that. So thank you, Louise, and you're very welcome.
Thank you, Angela. And I suppose first I'd just like to say a real thank you to everybody who supported us in getting to this point. It's been a lot of work, and I think the document hopefully will attest to the effort that has gone into it. But I suppose most importantly for an opportunity like this is to ask you to engage with us as we move forward, because we all know that lots of strategies get produced. They have nice, shiny, glossy covers, and they sit on shelves. And this is not what we want this strategy to be. This absolutely has to be implemented, not just for us in public health, but actually for the people that we work for, which is our population. So in that vein, we have a number of next steps that I'd like to share with you in terms of what we've been doing and what we plan to do. I suppose the first and most imminent is we'll be launching a dashboard of key performance indicators and population health outcome measures, and that will ensure that we're answerable to our population and that the monitoring of the strategy can be open to all and is very transparent. In the new year, and actually we've started work in earnest on it in any case, we'll be developing a public health strategic workforce plan and a competency framework. And really this comes back to what Dr. Henry was saying about we've been given an opportunity in public health with the investment and the reform that we have seen over the last number of years. We now need to make the most of that. And the way we will do that is supporting our workforce to enable them to be the best that they can be, to give them clear career pathways in terms of development, and to ensure that we optimise the skills mix that we have out there and a future-fit workforce. And this was a common theme with the expert advisory group of the strategy around looking forward to the workforce we need in 5 years' time. We will also be starting in the new year development of a public health communication strategy and protocol, and that will align with the HSE communications strategy as well, but ensure that we address areas particularly around health literacy that was a key theme with our focus groups and with those that we engaged with in the communities. We will, I suppose, fundamentally support the further integration of public health across the wider HSE, not just within the HSE, though we all know that this is a cross-sectoral endeavour and that the only way we will achieve this is if we all work. But I suppose what we'd like to see over the next 5 years is the core principles of public health being engaged across the HSE and really being the day-to-day business of what we do. And then the next one, which John always steals my thunder, he mentioned around developing and implementing a strategic action plan. So I suppose really importantly to us is making sure that this document comes to life, and I really hope that you get that across today from me in any case. What we want to do is ensure that this is implemented in its full entirety and delivered for our population. So we will be developing a strategic action plan. We've actually started the process. And the way we will do this is to align with operation planning and performance. So we're not trying to create more work, we're trying to seamlessly link the strategy to the day-to-day operations of public health. It's outcome focused with defined measurable goals and objectives. And the aim of that, again, is to support the monitoring and evaluation and adjustment, because we recognise that we might have a plan today, but we may need to change that plan to ensure that we're delivering. The way we have structured this is around 7 priority programmes. So we have a programme matrix approach to it, and those are the key areas that we will be focusing in the next 3 years. But I suppose more fundamentally, it's the right-hand side of this, which is about us being integrated. So we know in public health that we have national, regional, excellent people, excellent, but we need to bring everybody together to ensure that we deliver. So this will be an integrated approach to planning and action, and we will be then asking people, hopefully they will engage with this, but we will be asking for this to evolve into learning networks, because we know that it's lifelong learning with this process. So I just want to thank everybody again, and I'll hand back to Angela.
Thank you very much, Louise. So thank you, everybody. I'm going to sit down for this. It's probably a little bit better. So thanks, first of all, and thanks to Louise. I look forward to working with Louise myself in the action plan, and there's lots of work to do. So we're going to move on to the panel discussion next. So thank you to everybody who's joined me here. We've had lots of questions in online, and so thank you to all of you who've participated. It's great to see the interest. So just to say to everybody here on the panel, feel free to come in anytime. There isn't any rules around this. But Tibbs, I think it's appropriate I might start with you. Certainly, I think patients should be at the centre, so I think gives an important message, and there's been lots of questions actually veered in that direction. So from your perspective, I know you've hit on it already, Tibbs, and the question that came in is, how do we ensure that the strategy will actually change people's daily experience? And it's a bit hitting into what May said, you know, it's a nice glossy document, but how do you impact on the person there that we saw in the room that's living in such horrific, you know, living conditions? What's your sense of how the strategy could kind of be realised?
Well, I think the most important thing is to listen and understand what people are experiencing and the challenges that people experience, but also kind of at a really detailed level for each individual, because for some people it could be as simple as transport that's getting in the way. that's a real blocker. For others, it might be multiple reasons, obviously poverty and the living conditions as well. I think firstly, it is about going out, doing what you were talking about, May, which is about going to the communities and talking more directly with them. But also it's using, some big data, really advanced analytics, and to really identify, the areas geographically where we need to understand there's a particular problem, and then from that trying to get a little bit deeper and validate a lot of those insights by going and talking to people directly, and from there on, inform everything. So it's kind of hard work because you're really going into person-centered and that integrated care, including all agencies that could touch those individuals.
Is that your experience, May? I see you nodding there. I think it lines into what's going on in Limerick around the health equity piece.
Yeah, there's a few things. I think when Andy Burnham came over, he said, make the family the centre of, the whole thing, so that it's a big change, I think, for the organisations. I think the organisation has almost been at the centre, and that's for all organisations, so it's really about getting the organisations around each individual and each family, and that's what we're trying to do, putting them at the centre, and real co-production. I think it's a change for us, because we've paid lip service to it, if I'm very honest, in my view. But it is a complete culture change, really listening to our communities. But I feel, certainly in Limerick, I feel that that tide is turning a bit, that we've certainly got some amazing people who are very experienced in co-production. And I think the other issue is some of these poor communities, they've been communicated with to death. Yeah. There's lots of studies and stuff, and not much has happened. And I think we have to be very careful about trust with this community.
Yeah, I think we all know the whole community participation and what that actually means. Colm, would you like to come in there?
Just one of the really critical things that Michael Marmot did over the years was raise awareness across all sectors of government and society. And that's because they have such well-developed equity stratifiers in the UK, and we're quite behind in this. And once you start publishing data that differentiates access to healthcare or outcomes to healthcare, it begins to change things. Just the publication alone. And may I give some examples today. We know about single studies that have shown life expectancy in different groups. But what I'd like to see us get to, and Dermot is working on this, is we develop a suite of stratifiers for healthcare that then expose gaps in access to healthcare and in outcomes. We know that already. We have a public-private system. But I do think this needs to, if we got more refined at publishing that data and presenting it to the board of the HSE, to government, to try and influence policy and to shape a healthcare system that doesn't leave anyone behind, that will go a long way.
Yeah, thanks, Colm. Professor Horgan, did you want to say anything on that in terms of influence the policy side that could, I suppose, like we've rightly said, put the community more at the centre, or is there anything going on that would be helpful to understand?
So there's a lot going on, and I think we really need to acknowledge the frontline people out in the communities who really are the voice of people who mostly don't have a voice, or if they have a voice, they're not listened to. And we recently were invited to listen to Kildare child poverty, and the people were using the current infrastructure and really strengthening it. And while I'm always reminded that we are an ageing population, I'll have to say, because Abby and Ellen are here, we also have one of the youngest populations in Europe, with a quarter of our population being under the age of 25. And I think from a policy point of view, having our Taoiseach having child poverty as a major issue is really important. And what works is, as Colm and other colleagues, and May has it in action, is that cross-sectoral cross-department leadership in that area. And it happens in other areas too. And just to, I suppose, acknowledge work that Diarmuid O'Donovan and Greg Martin are doing with the department and with housing, local authorities and so on, really understanding where people live. I like to remind people we're all privileged, middle class, educated people here. And we have an onus, given how privileged we are, to really speak out, speak up for those, as I said, that don't have advice. And I know Eamon O'Moore's in the front row here. He's a huge, huge advocate for people who don't have that voice and are often dismissed. Yeah. But I do think it has to come from leadership at the highest level. When that is there, then things follow, people work together. And it has to be leaving our traditional silos where we're really comfortable in health. But a healthy population means a healthy economy, it means an educated population. And I think we're fortunate in this country to have a really good educational system. But I was taken, when May really highlighted the people not achieving that in that particular, I mean, it goes hand in hand. Yeah. So I think it's us working together, HSE, Department of Health, but much more beyond that, and having the data and the evidence that underpins the decisions that we make is absolutely essential.
Yeah, I couldn't agree more. And I mean, there is so much more as well go on in the whole area of Sláinte care, healthy communities, which again are the same approach, putting the community to the centre. So there's huge work and investment gone into that as well. So thank you. Dr. Henry. So Dr. Henry's just disappeared on me. That's fine. I suppose to achieve all this, we know, and Dr. Henry hit on it there earlier, there's been so much change in public health, particularly over the last 2 years, and the investment after the Crow Horse report. So, John, I might come to you. Like, how does national and indeed regional, because as you've rightly said, we now have, and to acknowledge our REOs who are here, we now have our regional executive areas, we have our RDBHs out there. How does national and region work together to achieve all the things we spoke about there and work across the organisations, not just within health, as Professor Horgan has said?
Yeah, I suppose integration has been a key theme from the very beginning over the last 5 years. I suppose we were charged and given a mandate to develop a new model for public health, a public health reform programme. And the word in that mandate was radical. You know, a radical new model, and I think we've established now a model that aligns with Sláinte care in terms of the health regions and the centre, and the public health strategic leadership team now includes the domain leads across those 5 domains for public health, but also the public health, the regional directors of public health. And in that way, I suppose regional and central teams are represented there. And I think that's crucial. And in the course of the last number of years, as a strategic leadership team, we've had huge support from HSE organisational development in trying to get some clarity in our thinking around what this means, an integrated way of working. And Denise Keoghan from Organisational Development has been on that journey right through, and again this afternoon we're looking at that again, because we feel we need to proactively give that time. Integration won't happen by accident, and it's essential in relation to the central and regional functions. But I think integration needs to go much further than that, and it's integration across the entire multidisciplinary workforce, not alone within public health, but across the HSE as an organisation, and then beyond that as well, where I suppose my ambition in relation to the implementation of this strategy is that population health approach and improving and protecting public health would become embedded in everybody's business and everybody's mindset across society, because we saw within the COVID pandemic that was the way of working through that emergency. There was we're all in this together approach and drive, and we could see what could be achieved in short time frames when that was the way of working. So I suppose I also firmly believe that throughout our very talented workforce across public health and across the HSE, that everyone in that workforce, absolutely everybody, is a leader for improving and protecting population health through their work, but also through their influence. You know, where we speak to families, we speak to friends, neighbours, and even in an area like the uptake of immunisations, which we're struggling with as similar to other countries at the moment. When we talk to friends, family, and any organisations that we're affiliated with, and we bring these type of public health and population health themes into the conversations, I think that's very powerful, and it means we can kind of spread our mantra and our strategic aims and objectives for population health.
Okay, thank you, John. Unfortunately, I've just been told it's time to wrap up, so that was very quick, first of all, so thank you, John. I want to say thanks again, particularly to our external guest, Professor Horgan, for taking the time to come to us, and again, the support you've given to us in the HSE. It's been reiterated many times to say a huge thank you to you. And similarly to you, Tibbs, I think, you know, we give tokenism often to the patient voice, and it's hard sometimes to include the patient voice, so having you at the table going forward, particularly in the development of the action plan, will be huge, so thank you. I want to say a particular thanks to everybody online. I hope you found that informative. As May has rightly said, we're just at the beginning. We're only on the first step of this. So we look forward to engaging you going forward. The strategy is there online. You should have access to that. There's also a post-webinar feedback that we very much welcome. And really just to say thanks to everybody here in the room for joining us this morning. I think Dr. Cuddihy has just one final point that he'd like to make, so I'll just hand it over to John.
And the final point, I suppose, is to thank you, Angela, for hosting so expertly. When you do it expertly, you'll be asked again. That's the only caveat. So this has gone out far and wide, so you can expect that. But I want to pay special tribute to Dr. Louise Hendrick, and special thanks in relation to her leadership and coordination and drive in relation to achieving this over a very short period of time, and to a very small team from Quality and Patient Safety initially, and currently Angela, Rachel and Kathy, and my own team, Niamh, Kelly and Sinead in the National Office, who work with the aforementioned. Thank you.
So thank you, everybody, and I'm just going to bring it to a close, and thank you once all again, and thanks to John as well. So hope you all have a good day. Thank you. Thank you.